not leave that for forever. You're going to shower, which I think is really necessary. Right? So, but now there's about 20 patients who have a fistula, maybe 20, who have done really well, and those are the guys who are they're starting to become 1 year old in terms of their treatment. And for them I do plasmapheresis, I do lidocaine and procedures, and that's the other thing. I do it because it's proven to be better. See, pain and ketamine and lidocaine and opiums, they use the same door to get into the nerve. But obviously, pain transmission molecules have a lot more preference. They hold on better to the receptor than opiates. Opiates hold on better to the receptor than ketamine and lidocaine. So if I can block the pain, and even if it's for a day or two or a week, and use that window of time to give them their central sensitization medication, and then it works a lot better, brings the pain a lot lower for a longer time. So these patients are doing better with this regimen. Instead of coming every 2 months for their boosters, they come every 4 months, every 5 months.
And are they still on medication, or is this the only medication?
They're still on medication, but because this is new, what we theorize is that eventually, if we keep it, we may bring it really back, the central sensitization, get rid of it completely. But we don't know, we theorize that it will go away, but we don't know how long will it take for it to really go away completely. But I hope that eventually it might happen. That's our hope. That's a theory, at least theoretically, sounds possible. Yeah. Any other questions over there?
What are the risks of doing something like that?
For the plasmapheresis?
And for the ketamine.
The ketamine. Ketamine is an anesthetic, dissociative anesthetic. What we have seen, and we're going to publish that paper as well, is elevated liver function tests that come down, and blood pressure goes up, only while you're getting it. But it always comes down. There was only one patient, she was 78 years old, who ketamine was working. From the increase in the blood pressure, she did not have a heart attack, but her troponins did go up. So we had to stop it. But cardiac cath and nuclear studies didn't show any lesion in the heart. Then hallucinations may or may not happen. We give Versed and Ativan, not to stop the hallucinations, but to make you not be concerned about it. Because adrenaline does not help CRPS. Adrenaline, nerves that are damaged have a special receptor for adrenaline, and that fires off an action potential of these nerves, increasing the input of pain. That's why going into withdrawal from opioids, that's why it's a problem to put a patient with CRPS on opioids, because you're trying to taper them off, and like what Dr. Alexander said, their pain gets worse, but it's not because you're taking the opioid away, it's because you're triggering a very prominent adrenergic response that makes their pain worse through these mechanisms. So being nervous while you're getting ketamine is not going to help the ketamine, but that's why we give Versed and Ativan. Clonidine can also help that. Clonidine also is given for blood pressure if needed, but we give it to all of our patients in the unit while they're on ketamine as well.
In your experience, for those that have suffered cognitive problems from CRPS, which of the regimens or treatments seems to have the best
cognitive
function?
I've seen it the best or the fastest, at least, with plasmapheresis. Plasmapheresis really makes them feel like they're out of the fog. That's what they say. Ketamine also does that once you're out of the ketamine fog. Yeah. Or maybe it's just because the ketamine makes you so when you're out out of it, you feel like better. Well, I can think. Oh, there, yeah.
Oh, so I had one-day ketamine infusion several years ago. And so I literally tripped all day. I mean, I brought my headphones and listened to Grateful Dead. So it was fun. But so they were doing it properly. Is that a fair assumption?
Did it help your pain?
Well, it was not present, yeah, but
Did it help your pain for a day, 2 days? Did it make it worse?
No.
You have a lot more nausea,
No, I was.
headache.
No.
Having hallucinations and tripping is we cannot avoid that.
Okay, because you were just saying.
Yeah, we give you Versed and Ativan to keep you calm. But we cannot avoid those hallucinations.
Oh, because you were just saying you don't have hallucinations.
No. I said you may or may not.
Oh, you may or may not. Okay.
Yeah. What we don't want is for patients to become nervous about it. Adrenaline. We need to stop adrenaline surge from happening. That's why also when we give it in the unit, we don't allow any phones, any visitors, because some patients, I don't know their interactions with their friends, but some of their friends or family members may make them really upset, and then it doesn't help.
How do you quantify central sensitization?
Like I said, spread after discharge and hyperpathia. Spread is a phenomenon when I prick you in a specific dermatome and it spreads to others. After discharge, I prick you and it stays there for a while. And hyperpathia, I prick you, you may not feel it as bad, but if I keep on doing it on the same spot, suddenly it'll be really bad and painful. That's how.
With the initial ketamine treatment, is it better for inpatient or outpatient in the beginning?
Well, no, it's very dose dependent, so the more we can give you, so is the better. Yeah.
For the inpatient?
It is.
It's better?
It is, yeah. Because it's a lot more. You get 40 milligrams per hour for 120 hours. The outpatient is 200 milligrams a day for 10 days. So it's almost like, I don't know, I'm not good at math, but it's a lot more. Right?
I have two questions, and the first one would be for those patients that, I'm going to go way back because when I was diagnosed it was RSD and it was in stages and not in. So what would be the protocol for somebody, for myself, that's going on 30 years of having this, to go into doing ketamine? Is it
the same?
I mean, there'd be no difference. It would be like like somebody who just got it yesterday.
Yeah.
There'd be no difference. The other question I have for you then is you spend the majority of your time talking about the burning sensation and pain, where there's so many other symptoms that come along with it. Would you say that it's the burning sensation that activates all the other symptoms, or is it something? I mean, is the ketamine take care of the? I pass out a lot. Does that take care of that? I mean, the ketamine, would that help with something like that?
Well, I would have to examine you, because if you're passing out a lot, do you have gastroparesis? Like you eat a little bit and you're full. You're nauseated all the time.
I'm always nauseated all the time, and
so
I always have
symptoms of gastroparesis. Maybe
severe burning pain in my stomach.
Right.
In my stomach, I only have one. I'm sorry, I pluralized it. So it's difficult to eat. When I do eat, I feel like I just got done with Thanksgiving dinner. I mean, it's terrible.
That's symptoms.
A lot of gastro, those types of things. I look at a lot of the symptoms that come up here, and I've studied this since I've been blue in the face. I've gone on 30 years, and I don't know. I get kind of confused when you start talking about certain different things and what could help. I've had 9 SCSs implanted in my body. So I just had 2 new ones implanted. I have 2 of them, so they seem to help. They take the edge off. You talk about the narcotics, the opioids. I know they don't work, they don't take the pain away if I take them like that. However, in the beginning stages, years and years ago, there was nothing better than going to the ER and getting morphine injected into me in 30 seconds because it gave me that euphoria and my pain was gone, you know. But then 40 minutes later, it was back again. So, I mean, those are the things that I've experienced over the years. And so, I guess, am I looking for that instant cure? I know that there isn't an instant cure. There's no magic pill or what have you. Going through the ketamine protocol, you know, and then going after the boosters and what have you, or you know, that's where I'm at. I'm like, you know, trying to make my decisions on. You know, 'cause once you get to a certain point with the pain, it's almost like normal. It's like you're used to it. So, you know, you have your good days, you have your bad days.
Right.
So, I guess that's my question. Is a lot of people say, well, if you weren't in the pain, then you wouldn't do this, you wouldn't do that. You know, I had the tilt table test. I was out within 3 seconds after they tilted me. I mean,
dry eyes.
You know, do I have dry eyes? No.
Dry mouth. There's a lot of things that I need to ask, and I'm not going to do it.
I only have one hand. So that was taken off because of the RSD.
Wow. They thought that might help. They thought that might
It actually became gangrenous and black, and it was decided that that's the best route for it.
Oh, all right.
It was actually, when it was taken off, I donated it to the University of Pittsburgh, and they have all the studies on it. So.
In any case, I would need to examine you. It's personalized. It is not a factory. It's not like you come here, you get this because that's the way you do it. No. It's personalized. Where you hurt, what type of pain, what other symptoms do you have, will lead me towards thinking, he did start it as CRPS, but now he's developed this or that and that and this and this and that. And I decide your best option treatment for you based on you. This is not a factory. This is not a ketamine factory. Right? This is, you think, or I think. And I determine and decide the best treatment for every one of my patients, based on every one of your symptoms. And I addressed every one of them until I either help you or not. So far, I have not been able to help. I've been able to help everyone. Yes, Mrs. Gay.
Hi.
How are you?
Good, how are you?
All right.
When Dr. Alexander looked up the list of other symptoms and so far it doesn't seem like it's been addressed, I have a question about tremors and shakes and movement disorder related to CRPS.
Yes.
Ketamine doesn't seem to treat that. And when I try to research that particular symptom, I can't seem to get much information on that.
The motor involvement of CRPS seems to stem from central sensitization. This inhibition of Renshaw cells and at the anterior horn of the brain matter in the spinal cord seems to be the mechanism of that. The best medication for that is baclofen. Ketamine helps maybe a little bit. Baclofen may be the best because of the mechanism of action and where it exerts this mechanism of action. When patients have that such bad motor involvement, then we try an intrathecal baclofen trial to see if it helps that. Sometimes it does, sometimes it does not. It's one of the hardest symptoms to get rid of, but it's addressable at least. And there is a mechanism and there is a theory behind why is baclofen the best. Anything that can reduce this inhibition in the spinal cord can help it. Lidocaine, IV ketamine, IV baclofen, and low-dose naltrexone can also potentially help that because of the way it works. Yeah. No worries.
Okay, a couple questions. My daughter started treating ketamine like 5 or 6 years ago. And when she had her first inpatient, she was having problems ketamine seemed to help with that.
Mhm.
At the time, she came in with a catheter and that one. However, at this point in time, she has a straight cath herself. And she also has gastroparesis. She talked a little bit about how the CRPS causes that or interferes with those messaging.
C fibers. Small nerves are divided into large and small. Large fibers are the guys who control your motor, your muscles, and sense vibration and proprioception, where your joints are in space. Without having to look at them, you can feel that your foot is like that, or you're crossing your legs, or what have you. Small fibers are the ones that sense temperature and pain. But they're also everywhere, literally everywhere in your body. And it's the wiring, it's what the body uses as wires to communicate the communication between the brain and the lacrimal gland, the brain and the salivary gland, the brain and the eyes, the brain and the heart, the brain and the gut, the brain and the bladder, the brain and the blood vessels, the brain and the nerves that go onto nerves, the brain and the nerves that go onto the bones. So they're everywhere. When you get them affected, you affect every one of them. Everywhere. So you get POTS. Patients get diagnosed with this postural orthostatic transient tachycardia syndrome, which is really just C fiber, a small fiberopathy. Then they get diagnosed with gastroparesis, which is the same. Then they get diagnosed with interstitial cystitis, which is the same thing. The trusor muscle, the bladder, is densely innervated by C fiber, small fiber. When they get affected, they constantly fire, they constantly push the bladder in, they make the bladder contract. That, along with the neurogenic cramp of the sphincter, makes these patients feel like they need to go to the bathroom. They sit down, nothing comes out after a few seconds. Frequency, urgency, that is again also a small fiber, a manifestation of small fiber neuropathy. That's why Dr. Whitmore here developed a concoction with substance capsaicin, irrigates the bladder with capsaicin, and what she's doing is just basically calming down the C fiber.
So with Katie, she can't go.
At all, but she does feel like she needs to.
They get quite a bit out when she casts herself, but she can't make it to now.
The sphincter is in such a bad spasm, and the bladder is in such a bad spasm. That is called trusor sphincter dysynergia. Typical of CRPS as well. Yeah. Maybe some Botox in the sphincter may help it, which I do.
Would you talk a little bit about how physical therapy becomes part of the treatment, or how it works in the program? You mentioned you're doing like the aqua therapy. Is that an ongoing thing or specialized?
It is, but only when pain gets better. I don't start off with physical therapy. Patients, they hurt from anything. So only when they start doing better do I start to offer, send you to physical therapy, to regain their strength, regain their muscle strength. That's it. It doesn't really help pain itself. It's a way to make them stronger.
So it's really nothing special, it's just after you're feeling better,
Yes.
moving forward.
Yes, that's it.
We need to stop here because we need to let Dr. Chopra do his presentation as he's calling back today.
All right. So just everybody who wants an appointment, write your name down on a piece of paper. All right? And I gotta go because I'm working. I have patients.
Oh, you have one to get up straight.
Okay.
Yeah.